We have two presenters today. First, we're going to have Annalisa Fischer, who is the Performance Manager for Safety and Quality in Surgical Services. Her role is to improve outcomes and safety across surgical services in conjunction with the surgical specialties, nursing, and anesthesia. So, Annalisa, I'll give the floor to you to present.
Okay, see my screen? Yep, great. Okay, so again, I'm Annalisa Fischer. I am the Performance Manager for Surgical Services, and in conjunction with Elena Gutman from Anesthesia and John Morton, the Vice Chair for Quality for Surgery, we have been charged this last year with optimizing our universal protocol, and I'm here to tell you sort of the why and the what. So just looking back over just about the last 2 years, YNHH had a number of serious safety events. And for those of you who don't know the definition of a serious safety event is something that reaches our patient and causes severe harm. And that can run in a scale from anything from having to come back and have a second procedure and undergo anesthesia again, all the way up to death. So SSE5 is the minimal that it can be, all the way up to SSE1, which is death. So when we look at our serious safety events, when we look at them, we do RCAs on them, and every single one is reviewed. And we looked for the gaps. And when we found, what we found in each, for about 6 of them, was that the timeout had a lot of opportunity for improvement. So we had patients who had the incorrect implant because it wasn't part of the timeout. We had unexpected OR outcomes because there was poor communication about medications that the patient was currently on, as well as plans for intraoperative medication. We've had situations where equipment's not in the room, not available. It wasn't known that it was going to be requested. It wasn't on the DPC card, wasn't on anything. So there wasn't a chance, they didn't catch it and they had to abort the procedure. We've had issues with instruments not being checked and that not being communicated. We've had patients slide off the OR table because people didn't cross-check the positioning that they wanted for their procedure, and making sure the patient was secure in that positioning, and also the wrong site surgery, which is the largest event in this case, where we operated on the incorrect hip of a patient. We have had other serious safety events before this one that also involved the timeout. We've operated on the wrong kidney before and had a couple near misses on wrong sites. So for urologic procedures. So a lot of opportunity in this. And this is one of the things that Dr. Kenny had cited when he was basically the co-chair of POPSQ, that really the timeout needed to be improved. In addition, when we looked at the sign out or debrief, we found that there was a lot of opportunity there as well. So this is just FY19. We had 113 total specimen opportunities. Well, what does that mean? We're talking about mishandling, mislabeling, wrong specimens in the wrong containers. Most of them were able to be processed to some degree. But we actually had 10 that were lost and unable to be processed, and actually resulted in either a patient having to come back or a lesser diagnosis or treatment plan, a plan that wasn't really helpful to the patient. Most notably is we had a patient who was unable to make a decision about whether or not to keep a pregnancy based on the loss of their amniotic fluid. So all that kind of triggered this review. They said, what are we doing out in the ORs? So we went through the ORs, we audited the drop-ins of about 40 ORs, and what we found is that it was highly variable. Everybody did it in terms of the timeout, but they didn't always do the final pause before incision, and they didn't always do the debrief. So we decided that there was lack of clear roles. Some places the nurses led it, some places the surgeon led it. It just was variable. There was no consistent checklist. Some people use the computer, some people work from memory. So you miss things. The pause or final timeout wasn't consistently done, and it was done pre-draping in some procedures. So site marking wasn't confirmed, or the actual area that you're going to be operating on wasn't reconfirmed. So if it's something that you couldn't see a site marking on, so say in the case of a ureter that it wasn't reconfirmed just before procedure start. So, and you don't do the final timeout, you also didn't have your positioning isn't confirmed and your antibiotics aren't confirmed. The debrief and sign out, we just explained it. We had specimen errors. And while specimens have a multifactorial reason why they fail and don't get to the right place, one of the bigger things that we noted was, one of the bigger things we noted was that they had opportunity, excuse me, somebody was putting something in the chat, distracted me. They didn't have any communication about it. So really what we've decided to do is have a very scripted debrief where that really prompts the attending to come to the bed, come to the computer, review every specimen with the nurse and make sure it's going to the right place, because we never want any patient to not have the correct diagnosis. We also just don't want to put you in the position of having to explain that to a patient. So, yes, go ahead.
And so I think it's pretty common for people to question why we actually do the timeout before induction and then have to do a pause. Why can't we just do one? One of the biggest problems Yale New Haven had with safety was people getting unnecessary induction of anesthesia. So what was happening was people would get induced, then we would do a timeout, realize that we didn't have the right equipment. That was the most common thing. Or didn't have something else that was necessary to do the operation. Then the patients would get woken up. And that was counted as a serious safety event. And so timeout was moved to pre-induction to try to prevent that. And it's been very effective. The reason for the pause is that when we're verifying the sidedness of the procedure before induction of anesthesia, people then get anesthesia, then they get positioned. And the unintentional consequence was the possibility of people getting wrong site surgery because we hadn't verified the sidedness again. And that happened actually just a few years ago here. So the idea of the pre-induction timeout is to make sure that we don't do unnecessary anesthetic. The principal idea of the pause is to make sure that sidedness is correct and to verifying the site marking.
Correct. Thank you for that. Back in December, we got a small group together of surgeons, anesthesia, nursing, surgical techs. We created a tool. Then we took the tool and iterated it, I don't know, I think 40 times throughout all the ORs. And actually Dr. Kenny was one of the people who trialed it with us and gave us a lot of feedback on it. And every time we trialed it, we would iterate it and figure out what needed to stay, what needed to go. And we came up with this. This is actually a handheld tool that will be on the folders in the ORs. So actually the folders with your paperwork, paperwork will be in there, and on the outside will be this tool. And we figured that was sort of an elegant way just to keep it all in one place, since you're looking at your consent anyway. So sign in. So why are we changing the names? So as frustrating as that can seem, many of you go across hospitals. Some of you are at L&M, some of you are at Bridgeport, and some of you are at Yale New Haven. And what we heard loud and clear really from the urology department was that they wanted it to look the same and having the same names. So having the pre-induction at L&M, they weren't doing, and really still aren't to a point, a pre-induction check. And now, and they called it something else. And then we called it something else at Bridgeport and called it something else at Greenwich. So we aligned the nomenclature to the WHO. So now it's called sign-in. So the pre-induction, what we called timeout, is now called sign-in. What is the difference? We're doing our introductions first while the patient is awake, making it a little more patient-focused. And everybody's very scripted and has a role. And everybody's got a checklist that they can look at that will prompt them. And that is really what this is about, so you don't forget anything. There is also more team inclusivity. You will notice the surgical scrub has a role, a defined role where they need to speak. And for them, it's if there are instruments that are checked and ready, making sure everything they have. And if they don't have everything, making sure it's communicated that something's still in process to give you as the attending the opportunity to wait or to proceed. And medications on the field, making sure that those are understood as well. Anesthesia just kind of wraps it up and makes sure that they confirm their medications, any special considerations, and then moving forward. As we said, the final timeout, which people should be doing, or the pause, is that just the incision, just before that incision, you just check one more time that that patient's in the right position, that you can see the site marking. And if you can't because it's draped, so a ureter, for example, that you're going to reconfirm with your imaging and make sure that you have everything, that, you know, that's everything going in the right, correct direction. Dr. Kenny, any more comments before anybody else?
Just one question. Did you want to mention the use of fluoroscopy for unilateral stents?
Why don't you go and do that? Because I think I'm less good at that, understanding that. But go ahead.
So there was a safety event at our hospital in almost 10 years ago now, related to a stent, essentially a wrong-sided procedure on a ureter, and the fluoroscopy image was flipped. Anytime you have this type of DPH reportable event, the hospital has to come up with something called a corrective action plan, which is a plan we submit to the state, and then we're bound to comply with. And then if there's another event and we didn't comply with the corrective action plan, it's a really big deal. So the corrective action plan that was decided upon, and this is, you know, again, a long time ago, was that we would, you know, in cases where we're using fluoroscopy, where we would put a clamp or something similar, radiodense object, on the side that we're operating on when we shoot a picture, to make sure to verify again the sidedness. The challenge that's imposed is that for any unilateral stent, essentially it's been interpreted as requiring fluoroscopy. And so when colorectal calls us to place stents, they're now asking us to do bilateral stents because we don't have fluoro. And we don't have to wait. So then we've had obviously the downstream effects, sometimes negative, of having bilateral ureteral stents in place. So no one really thinks that's a good solution, and it's also I think very few people are actually still doing that thing where they're putting the clamp on the patient. So we're trying to, there will be a new policy or procedure coming out around that, that essentially does not require fluoroscopy for a unilateral stent placement that's placed endoscopically, but will require us to do really a sidedness pause to confirm the side, to confirm that you're actually visualizing the ureter and all that kind of stuff, in order to try to prevent us from having to do fluoroscopy or bilateral stents to prevent the sidedness problem. But that hasn't quite been rolled out yet, but that is soon to come.
Thank you. And then finally, the sign out. So if you look at that sign out, you'll see that when you break scrub, this is not at the way end of the case, this is when the attending breaks scrub, they leave and they look at, if they have specimens, they stop it with the circulator and they check and they reconcile that they're labeled correctly, because sometimes we've had female specimens like ovaries labeled with men's names. We've had, so we've really had incorrect labeling, making sure the visual confirmation is there, that the right thing is in the right container. Anatomical identification, laterality in particular, are very important in one of our larger issues that we have to correct. And then correct order, matching the requisition as well. And then making sure your procedure that you performed is correct. You do your normal wound class pieces, estimated blood loss, any issues, what went well, what you need to correct, if there's any equipment issues, and then you can leave. And the rest of the piece of this is that you're available for any count issues, obviously, but the rest of it is a checklist essentially for the rest of the staff to make sure that they do what they need to do. If you are a pediatric, are doing pediatric procedures, pediatrics will be still doing their sign-in with the pediatric patients under the age of 18 will be asleep when the sign-in is performed. That is something that they've decided to stay with at this point. And then the final timeout, again, if you're intubating and then you're repositioning somebody and redraping and doing all of that, you need to do another pause just before you cut the patient. That is really something that is best practice. So that's why there's a sign-in and final timeout. Otherwise, it's really no different. And we're really working to align that. Any questions?
I have one question. So
Sure.
is it the same across all sites, all Yale, New Haven sites?
So all Yale, it will be. So this doesn't go live until September 15th. but it will be across all Yale New Haven Hospital at this point. We are going to be spreading it everywhere, but it's going to take us a little time because there are such differences. But yes, doctor, it'll be at, so any children's hospital, but children's will probably try to spread this faster, to be honest with you, because they have that.
But it just hasn't been implemented yet, though.
No, September 15th. This is just I'm trying to get to everybody ahead of time.
Got it. Because I was at Bridgeport 2 weeks ago, and they did the timeout in the pre-op area, and they didn't include the surgeon. I was a little surprised.
Oh, yeah, no. So we will be working with them as well at Bridgeport.
Okay.
Yeah, but it's just not there yet. Thank you. Any other questions?
I had two suggestions actually. One is at the timeout, I always think it's a better idea if the patient identifies their name and date of birth rather than someone reading it, because the label could be wrong label as a possible problem. And the patient's awake. That's the whole point of it, doing it while they're awake. That's one. Two, this may be hard to implement and designate exactly who's going to do it, but I'll tell you that by the time the pause comes around and people are ready to get going and they've already done the timeout and it seems like an extra step to combat the frequently thought process of, well, we just did this, and you just kind of go through rote memory to just check that box that you did it, since the point of it is to make sure the right side is the correct side is being operated on. I would think that you would probably reduce errors even further if someone who was a non-surgeon had to say the side and then the surgeon had to confirm it. I don't know exactly how to implement that, because they could look at a CT scan and say, oh, that's the side of the liver that you're operated on, or they could look at the report or something. But it would combat that sort of, oh yeah, that's what it is, let's just keep going.
So interesting. That's the reason the anesthesiologist has to say the position. They're at the head of the bed, and they know they're just doing the positioning now, like just what side is up. I don't know if that's helpful in your guys' cases, but when you talk about orthopedics, it's nice because they say right side up, and then you know that you have the wrong side up. But yeah, I know it would be helpful to have somebody who does it. But when you have the whole idea of the imaging, it's harder to have that happen.
Because the anesthesiologists are just going through the rote thing too. He's at right side. He's a lateral decubitus. Oh, he's supine. Oh, he's in dorsal autonomy position. They're not really thinking about the side of the operation. They're just checking a box too.
They are. I think it's supposed to improve that communication though, and have you guys, everybody be listening for that. And we're really trying to get them to understand that piece of their role in it as well. It's a struggle, I'll tell you.
One of the hardest.
Go ahead.
One of the hardest things is that these are infrequent events, right? And so we're making a change to every single case that happens. And it's literally, we do 50, 60,000 cases a year or something like that, in order to try to prevent a handful of events. And so most of us in our career could probably do a really sloppy timeout and be just fine. But it's those devastating, very infrequent events that we're trying to prevent. The idea is that for stuff that's truly safety oriented, we want to be as reliable as an airline taking off and landing, right? And we're willing to accept some inefficiency in order to try to achieve perfection in terms of safety and reducing serious safety events. The analogy that we've used in the past is that, airlines are incredibly reliable at actually getting the plane to take off and land in the appropriate spots and safely without crashing, but they're not reliable at all with your bags, right? I mean, so they're focusing on the stuff that's super important. And that's the same thing in the OR. And so what it takes is everyone's got to recognize that these are the fundamental things that essentially are never events, and you have to be able to accept 2 minutes of inefficiency in order to make it certain that in your career it'll never happen to you or your patients. But the real challenge is going to be when, after this gets rolled out, when people have an event that was timeout preventable and they documented that they did a timeout, but they just did a really sloppy one. It's inexcusable. Everyone just has to stop and do this right. And, you know, just don't get creative, just read down the thing. And that's really it.
Yeah. And Dr. Singh, about the patient reading their own name or confirming it, many of our patients have received medication and they would say yes to anything. Yes, they do know their name and date of birth. So we did go with a team member because we do have plenty of patients who can't do that. So we just went with this. It was sort of we did have a whole bunch of conversations around it in our iterations. Do we just have them say it? And most of the time you're checking that anyway, bunches of times. By the time you're saying at this point, this is probably the 10th time you've checked their name and date of birth. Because people check them as soon as they come in the room. Let me see, I got another question. All right, any other questions, comments? So what's the next steps? So right now the staff is all being educated on it. We're gonna be starting simulations in the next 2 weeks, and then go live is on the 15th of September. And there will be one big go live across all our pavilions and sites. And we are going to be we have some leadership who will be around just to answer questions, because I'm sure we haven't, you know, there's going to be little issues or things that go on that we didn't think about, like that come up. So we're going to be around for it for 2 weeks for questions, concerns. We have gotten to every faculty meeting pretty much. I have like 4 more to go. And if we get this up and live on the 15th and have a good rollout, again, this checklist is really for your use and to help you just not forget something, because how many cases a day are you doing? So many. So it's just really, it's a tool that's going to help you not have anything happen. I'm sorry that took longer than I thought. I apologize. There is a video that I can send out to have Dr. Kellner send out to everybody that has Dr. Yu being a very bad surgeon, not doing a good timeout, and then followed by the how we want this process to look. Any other questions?
Thank you, Annalisa. We appreciate you coming today and sharing this with us. And I think we'll all take this seriously. And as surgeons, we have to be the leaders in the OR and make sure this happens the way it's intended to protect patients. So we're going to go on to our sub-I, Jeremy Green's presentation today. Okay, so I'd like to introduce Jeremy Green, who is our sub-intern from the Frank Netter School of Medicine at Quinnipiac University. Today he's going to be talking about implications of positive surgical margins and pathological upstaging after partial nephrectomy. So Jeremy, do you have control of your slides?
Yes, and can you guys hear me?
Yes, I can hear you.
All right, perfect. So thank you for that introduction. And as Dr. Kellner just said, my presentation will be on the implications of positive surgical margins and pathological upstaging after partial nephrectomy. So this will take the form of a case-based presentation, and along the way, I'll be bringing up relevant research topics as they arise. So our patient is a 68-year-old woman who initially presented to Griffin Hospital with a chief complaint of muscle spasms. She, at that time, underwent imaging, which revealed an incidental left renal mass, and she was subsequently referred to Yale Urology. When she was seen, her renal mass was asymptomatic, and her review of systems was non-contributory, consistent with her past medical history, which can be found here. So just a few quick things that I want to highlight. One, she had a past history of both hypertension and obesity, both of which are major risk factors for renal cell carcinoma. She also had COPD and severe spinal stenosis, which affect her health at baseline and her day-to-day functioning. Medications are also listed below, and she had no known drug allergies. Can you guys still see my presentation? Sorry. Okay, great. And so moving on, her surgical history, she did have a past history of abdominal surgery, which is always relevant when you're considering additional abdominal surgery, as it may affect your management planning, your access, as well as your intraoperative findings. I also want to emphasize that she did have a history of tobacco use, smoking up to 2 packs a day. A specific pack years calculation was not documented, but tobacco use is another major risk factor for renal cell carcinoma. Importantly, she had no family history of urologic malignancy. So on physical exam, she was hypertensive and had mild tachycardia, consistent with her past medical history of hypertension and COPD. Otherwise, her physical exam was unremarkable. Specifically, I do want to note that she had no palpable abdominal masses, and she did have surgical scars noted from her previous incisions. So this is the ultrasound from her initial encounter, and the main takeaway here is that she has a well-circumscribed solid lesion in the left lower pole, measuring about 3.4 to 3.6 centimeters in each dimension. And then she was sent for further imaging to further characterize this mass. So here is her CT. So on the left here, we're scanning from superior to inferior and then moving back up into the mass here. So this just confirmed our finding of a left lower pole mass. Importantly, it was shown to be solid and heterogeneously enhancing and measured 3.9 centimeters in diameter. A couple other points that I want to make is although the mass is slightly below that polar margin, it is very close to the polar margin and very close to the renal hilum. Additionally, it's also very close to the collecting system, which makes it a little bit more complicated in nature. So here are her labs from her initial encounter. So she had a comprehensive metabolic panel, as well as some additional labs looking for possible paraneoplastic syndromes. So importantly, I want to note that all of her labs were within normal limits. And critically, in terms of renal function, her creatinine was below 0.6 and her eGFR was up close to 100 at 96, indicating that she has good renal function, which is critical as we will be considering renal surgery. So our patient is a 68-year-old female with a history of hypertension, obesity, and tobacco use, presenting with an asymptomatic 3.9 centimeter solid contrast enhancing mass in the left lower kidney found incidentally on ultrasound. So just a little bit about small renal masses in general. So small renal masses are defined as renal masses less than 4 centimeters. And with the increased use of advanced abdominal imaging, including CT and MRI, the rate of detection of small renal masses has been increasing. Also importantly, there's been significant stage migration as over half of renal neoplasms are now stage 1 at diagnosis, meaning they're both localized and less than 7 centimeters in size. And so you can see below the pink and the yellow on this chart, which spans from the 1980s through the 2000s, showing that rising incidence of stage 1, detection of stage 1 malignancies. So here's a broad differential for a renal mass in our case. High on our differential should be renal cell carcinoma, as a majority of contrast enhancing masses do end up being renal cell carcinoma on pathology. There's also an array of benign renal masses, which are listed below here. The patient could also have a secondary malignancy or an infectious etiology for her renal mass, all of which are listed here. So a little bit about renal cell carcinoma specifically. It's the 7th most common histological type of cancer, and the incidence has been increasing worldwide. Clear cell carcinoma is by far the most common histological subtype, although there are several others. 40% of patients eventually die due to disease progression, which makes renal cell carcinoma the most lethal urologic malignancy. And that stands in stark contrast to a disease like prostate cancer, which is much more indolent. So as I've already discussed in this case, 3 major modifiable risk factors for renal cell carcinoma are smoking, obesity, and hypertension, all of which were relevant in our patient. The other thing that I want to emphasize is that the patient presentation can be highly variable. Your patient could be asymptomatic or present with very nonspecific symptoms like fatigue, weight loss, a general sense of malaise, fever. There's a classic triad associated with renal cell carcinoma, which is a palpable abdominal or flank mass, flank pain, and hematuria. But as these masses are being diagnosed at earlier stages and at smaller sizes, that classic triad is becoming less and less prevalent, now present in less than 10% of cases. And as I mentioned in the lab section, there's also a wide array of paraneoplastic syndromes, which also add to the great variety of ways that this can present in your clinic. So in terms of management options for these small renal masses, specifically for stage 1 disease, which again, local, less than 7 centimeters, partial nephrectomy tends to be the mode of management of choice, specifically because it yields equal oncologic outcomes compared to radical nephrectomy with the added benefit of preserved renal function. So radical nephrectomy is an option specifically for patients with larger or more complex tumors, but there is the added risk of chronic kidney disease, and radical nephrectomy itself is associated with a decrease in survival. There are also ablative techniques, which are less invasive, but are best used for masses that are less than 3 centimeters in size. And for these techniques, they're good for patients who do not want a more invasive procedure or for patients who are poor surgical risk. There's also tumor nucleation, which is a newer method of management. And instead of doing a sharp resection, what you're doing is bluntly dissecting between the tumor capsule and the healthy renal tissue. So the benefit is that you're able to preserve as much healthy functioning renal tissue as possible. So this may be a good option for patients in which CKD is a concern. And as always, surgery does not need to be your first option, and active surveillance is becoming an increasingly useful tool as these masses are being diagnosed at earlier stages. So data shows that 20 to 30% of small renal masses are benign, and less than or greater than 50% of malignancies are low grade at diagnosis. So there is a large number of masses which could be safely observed, and you'll just want to keep track of the size of that mass and growth rate with routine imaging. So our patient eventually underwent a left laparoscopic partial nephrectomy. Following resection, the resection bed was fulgurated using the argon beam, and the base was closed with a running V-lock suture. A couple other important notes from the surgery. One, the perirenal fat was intentionally left on the kidney tumor. This not only served as a helpful holding mechanism during the procedure, but it also allowed for that fat to be resected with the tumor, allowing for adequate staging. The resection was also noted to be very close to the ureter. After the procedure, the specimen was sent to pathology and the patient was admitted to the floor and subsequently discharged on postoperative day 4 to short-term rehab. Her stay was prolonged by an active episode of depression as well as significant mobility issues, which led for PT to recommend short-term rehab. So here is her pathology report. So she was diagnosed with renal cell carcinoma, clear cell subtype. The tumor was 3.4 centimeters in size. And importantly, the histologic grade was 3 of 4, which is considered high grade. And she was pathologically upstaged to stage T3A due to extrarenal extension into the renal sinus fat. She also importantly had a focally positive margin at that point. So let's talk a little bit about surgical margins in partial nephrectomy. So historically, 1 to 2 centimeter margins were used to ensure complete resection and adequate cancer control. However, there was this landmark study in 2002, which asked the question, does the size of surgical margins in partial nephrectomy really matter? And so what they did is they retrospectively analyzed the margins following partial nephrectomy using microscopy and correlated with follow-up with a mean follow-up of 4 years. What they found is that there was no recurrence in 44 patients with negative surgical margins. 42 of those margins were less than a half centimeter in size, and the margins range from 0.05 to 0.7 centimeters. Based on this finding, they recommended taking a minimal margin of less than 5 millimeters of normal renal parenchyma, which would allow for maximal preservation of functioning renal tissue. So to reiterate the big picture question, do surgical margins matter in partial nephrectomy? The answer is that margin size is irrelevant as long as it's negative. Now, if the margins are positive, that's a completely separate discussion. So on the topic of positive margins, they occur in less than 7% of cases after partial nephrectomy. And that rate varies a little bit depending on the specific technique used. Now, historically, some physicians did use intraoperative frozen sections in order to help minimize the risk of positive margins. But over time, they were shown to have questionable accuracy due to a discordance with final pathology. And there was also an unclear significance of positive margins. Studies have shown that they were associated with the use of frozens was associated with increased costs and operative time without a clear benefit. So there's two scenarios that can play out in the operating room. One, if the surgeon is willing to wait on pathology, you'll have increased warm ischemia time and you'll take on the risks associated with that. Or some surgeons will start closing and they'll hear from pathology sometimes after they've closed. So if the physician isn't willing to reopen and do an additional resection, then there really was no utility of taking that frozen section. So there is mixed literature on the significance of positive margins. Historically, studies have shown no association with recurrence. However, recent reports have found a significant relationship, specifically in high-risk disease, which is stage T2 or stage T3 tumors, as well as high-grade malignancies. So here's a study coming out of LIJ from 2016 in which they reviewed over 1,200 patients who underwent partial nephrectomy for localized renal cell carcinoma. What they found is the overall recurrence rate was 5.6%. However, in their high-risk patients, that number almost doubled to 10.3%. So on statistical analysis, they found that positive margins were significantly associated with rate of recurrence in high-risk cases. However, positive margins were not associated with recurrence in low-risk cases. So again, to reiterate the big picture question, do positive margins matter? Well, the answer is that it depends. In high-risk disease, positive surgical margins are significant, but not in low-risk disease. And you can see that here on this slide. So high-risk patients had a recurrence rate of nearly 45% in 5 years if they had positive surgical margins. And that's evidenced by this golden yellow dash line here. Now, the green dash line is your low-risk positive margin patients. And on statistical analysis, there was no significant difference in recurrence-free survival relative to those patients with negative surgical margins. So let's talk about the management of positive margins. So the recurrence rates after positive surgical margins are generally low, but as we just talked about, that depends on stage, that depends on grades. So this decision needs to be individualized based on patient's risk. So the management in general, the recommended management is vigilant surveillance. That allows for early salvage intervention in most cases. There was a study looking at the rate at which residual tumor was found in patients who underwent a second procedure specifically due to positive margins, and less than 39% of patients were found to be harboring residual disease. Now, it's possible that that positive surgical margin, which is being found in pathology, if the surgeon is undergoing or using sufficient cautery, like we use the argon beam, that could ablate that tissue, making that positive margin irrelevant. Now, there are alternatives to surveillance. You could do a repeat partial nephrectomy, which is associated with significant complications and is known to be a very difficult and technically challenging procedure, or a completion radical nephrectomy, which should resect all residual disease, but it's associated with CKD and a decrease in survival, as I mentioned earlier. So another topic that I want to touch on is pathological T3A upstaging. So assessing fat involvement is very difficult by traditional imaging like CT or MRI. Some of these findings are microscopic in nature. So unfortunately, this is often a post-operative diagnosis. And that's unfortunate because it's been shown that these patients would benefit from a radical nephrectomy in contrast to a partial nephrectomy. Now, this upstaging occurs about 5% of the time in clinical T1 cases following partial nephrectomy. It is associated with increased rates of high-grade pathology and positive surgical margins like we saw in our case today. So here's a study coming out of the University of Michigan from 2018 in which they reviewed almost 2,000 clinical T1 masses, 95 of which were pathologically upstaged to T3A. These patients were then matched by age, performance status, histology, and grade in a 1-to-2 ratio, and outcomes were compared. So what they found is a significantly increased rate of recurrence in the upstage T3A patients compared to T1 controls. They also found that T3A upstaging was associated with a significantly worse prognosis than organ-confined disease. And you can see here that recurrence-free survival, cancer-specific survival, and overall survival are all significantly decreased at 5 years. So this discussion of risk inevitably leads to the conversation about follow-up. So follow-up is really important because a significant number of patients, about 50 to 80%, are asymptomatic at the time of detection of recurrence. So that just emphasizes the importance of staying on top of your routine labs and imaging. Most recurrences do occur within 3 years, which needs to be factored into the surveillance protocols. But as we've been talking about, recurrence rates vary greatly by stage, grade, and possibly surgical margins. So this all requires an individualized approach. So you can see here that both recurrence rate and the median time to recurrence vary significantly between T1 disease, which is 2%, median time 38 months, to T3 disease with a recurrence rate of 39% with a median time to recurrence of 17 months. So unfortunately, in terms of follow-up recommendations, there is no standard protocol. However, there is consensus on what should be included in a follow-up regimen, which includes regular history and physical examination, as well as laboratory testing and routine imaging, looking for both local regional recurrence in the abdomen, as well as metastases, which revolves around chest imaging. So as I mentioned, there are no consensus guidelines, and there are variations from several well-respected organizations. So I pulled the 2013 AUA guidelines here, and I just want to emphasize the range of guidelines. So in low-risk disease, after baseline imaging, you will image again yearly up to 3 years. But in moderate to high-risk disease, they recommend imaging every 6 months for the first 3 years, and then yearly until 5 years. So this is a protocol coming out of UCLA. It's the UCLA Integrated Staging System, which is both a risk stratification tool, which corresponds to a surveillance protocol from there. So they use stage, grade, and performance status. In this case, our patient would have been considered high risk. And then based on their protocol, they range from in low risk cases doing abdominal imaging every other year after baseline at 2 and 4 years, to in high risk patients doing imaging every 6 months for 2 years, yearly to 5 years, and then every 2 years until 10 years. So for our patient, in terms of follow-up, she was supposed to follow up at 6 months after surgery. Unfortunately, at 7 months, her follow-up coincided with really when COVID was escalating in our region in around March and April. So she had been unable to obtain her labs and imaging. I pulled the EAU guidelines here, their COVID-19 renal cell carcinoma guidelines, which recommended not delaying follow-up by more than 3 months. So she should have been seen within 9 months. She was eventually seen at 10 months, which showed a local recurrence. And you can see on the left, we're scanning inferiorly and then are going to come back up into this mass. So you can see this recurrence, an enhancing lesion extending into the left inferior calyx. So quickly on management of local recurrence, options are similar for primary disease. You could do a partial nephrectomy, completion radical nephrectomy, ablative therapies, or conservative management. Relevant in our case, she had high-risk disease and rapid recurrence. It had been shown that for T3 patients, a completion radical nephrectomy is the best course of action. So importantly, in our case, she had adequate renal function, so she eventually did opt for completion radical nephrectomy. Now, there's very limited literature on the outcomes of local recurrence for surgical management. The studies are very non-homogeneous. A lot of case reports are small studies, so there really are no long-term outcomes to look at for evidence. However, there is some evidence supporting surgical resection after radical nephrectomy, as this one study in 2014 showed better cause-specific survival in comparison to observation alone. So that is the end of my presentation here. So I would be happy to open up to questions. And I also want to thank Dr. Singh for working with me on this case.
So Jeremy here, this is Dr. Kellner. So I have a question for you. So if someone has a low risk disease, but it's a positive surgical margin, do you think they should be followed even more closely than what's recommended in the different guidelines?
Yeah, so I think that's a great question. So what they showed in that study, which I can get back there, what they found is that patients with a positive margin but low risk disease had a equivalent recurrence rate relative to those with negative margins. So in that case, I don't think that that necessarily warrants additional follow-up. Now that may be different. For example, in our case, we had a focally positive margin. Now, if you had a grossly positive margin, that may affect your decision-making. But currently, I don't see any evidence that would require a low-risk patient to be considered high risk in those cases.
Thank you.
So, Jeremy, let's say you did the partial nephrectomy on the patient the first time around.
Yeah.
What is your take-home point on the role of frozen section? Would you ask for one, not ask for one?
So the evidence that I saw advocated for not asking for frozen sections in general. So like I said, the accuracy of frozens were questioned, and the rate of positive margins is relatively low. So in all of these cases, we're playing a numbers game, and we're trying to not just do, in one particular case, it may come back to bite us. But for example, if we're looking at this patient, I think that that the surgical management was correct. In this case, if you found out that you had a positive margin at the time, you may have considered going back in, but it was only focally positive. I really don't think it would have changed your management strategy.
Yeah, I agree. I mean, I think other really important point is that, you know, if you look at the surgical oncology literature, they talk about R0, R1, and R2 resections, right? So R0 is negative margin, R1 is a microscopic margin, and R2 is gross. And so I think one of the things that most of us who do partial nephrectomy do is very carefully look at the specimen and make sure there's not a grossly positive margin, because a grossly positive margin is a far different animal, we think, than a microscopic positive margin.
Yeah.
And so I agree. I mean, I think I used to routinely do frozen sections, and I changed my practice based on the literature, but also based on personal experience of having several, 2 or 3 called microscopically positive, and then one of the, and then they were not. And then I re-resected tissue. All that tissue was negative, and the margin was what the initial margin was not positive. And so that's a frustrating, really a frustrating thing. So there can be harm to doing it.
Hey, Jeremy, it's Eric Giraldi. I had a question. Nice presentation. The 2 studies that you looked at, the LIJ study and the multi-institutional study, and those patients who recurred, did they shed light on how many patients recurred systemically versus locally? I'm assuming most of them were local, but do you recall from those studies?
I'm not certain off the top of my head, but I'd be happy to follow up with you and connect you with that study.
But there's a study from the NCDB that Simon Kim was a co-author on. This is like, I don't know, 3-4 years ago, something like that, that showed a difference in overall survival. It was statistically significant, very small difference, like 1.5% or 2% overall survival difference, suggesting that, that margins may actually have a real role in for high-risk patients in the actual disease process, not just local recurrence that you can always just resect.
Jeremy, that was a great talk, very well presented, really well formulated data. I remember one of the authors of one of those studies, I think it was the LIJ study, was saying that he enjoys telling the family postoperatively in the immediate postoperative period that the margins were negative, and that's the main reason he sends margins, is just for, you know, some good news to provide the family that we got it, things like that, as opposed to actually driving immediate management.
Yeah.
How many people have done a recent completion nephrectomy after partial? Nobody?
I think another interesting idea is, there are people who will do, biopsies of the resection bed after doing a partial nephrectomy and call it final margin. And then what that can do is, convert someone from a positive margin to a negative margin, because if the surgeon calls it final margin and that final margin does not contain cancer, then the final margin is negative. And so that's a practice that some people will employ that I think is probably, my personal take on it is it's not a great idea. Anyone think other thoughts?
I agree. All that's analogous. Most of these comments are analogous to intraoperative margins taken during prostatectomy too.
If you do have an interest in this case, Dr. Singh and I have been talking about it. This case is actually going later today. So very relevant for grand rounds this morning.
Great job, Jeremy.
Hey, nice job, Jeremy.
Excellent presentation. So, all right, are there any other questions or comments? Okay, well, I think this concludes grand rounds. Good luck